largely built for the emergency care of patients who visit our emergency departments. We know largely that the practice of emergency medicine is ever growing in our nation, and what an opportunity and best way to actually usher ourselves into this lovely program. Today, we are going to be joined by a group of experts who are going to run us through a case titled My Body is Paining, a famous presentation by those who have been visiting the ED for non-specific reasons, but they will continue saying, My body is paining. And just to bring you into the light of what is going to happen, we are going to have presentations from pre-hospital, in hospital, down the path of where you will be answering questions through the polls and having expert opinions. And we are joined by our expert today, who is Dr. Joseph Emuron, famously an emergency medicine physician, paving his path in the northeastern part of Uganda, Katakwit district. And we have a clinical mentor in Dr. Amon Banturachi. We have Maria Natasha, a fifth-year medical student, and Bagonza Melvin. We are so proud to have you today, and I wish all of you a fruitful enjoyment towards this scenario, which is the eighth of our presentation, this series. Thank you very much. Allow me welcome Bagonza to introduce. Bagonza,
Good,
if you may unmute and we start. All right, good, 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 good.
good evening, ladies and gentlemen. I am Bongozana Melvin, an EMT presenter. Here with the presenting complaint of a 35-year-old female presented with severe generalized body pain for 2 days. And in pre-hospital care, we normally have organizations that you normally make prior going into for a response, and in which for this response we have the staff members who are 2 EMTs and 1 ambulance driver, a patient who is 1 but currently a non-emergent patient, and the equipment that we may need and the medications for this response are communication devices like the walkie-talkies, patient monitors for the vitals, the normal saline, or we'd love to have an oxygen source, nozzle prongs, syringes, non-rebreather masks, giving sets, cannulae, pen light, simple face masks, antibiotics, and then analgesics, but the IV crystalloids. Then for this case, the mode of transportation will be a type B ambulance. And then the documentation or handover would have the dispatch notes with the vital signs. And in this case, after going through the ABCD and after the on-scene care, we give in a handover report, which is given in as an ISBAR acronym. And for this case, we have, for the identification, we have I am Melvin, an EMT called to pick up this patient. This is a 35-year-old female presenting with sudden worsening generalized body pain for 2 days and bilateral knee swelling. On assessment, air was patent. Patient had mild respiratory distress with rapid pulses, bilateral swollen knee joints and fevers. And en route, we administered oxygen. We gave the patient morphine, and we gave the patient PCM, which is a paracetamol. And for the recommendation, continued IV fluids and oxygen supplement, morphine after every 4 hours, the paracetamol to be continued, and a review by the physician.
Thank you so much, Melvin. My name is Maria Natasha Namoja from KRU, and I'll be taking us through the rest of the presentation. So, when we received our patient from the pre-hospital team, we wanted to do a primary survey in the ED. So we assessed our patient's airway, and it was patent. We assessed the patient's breathing, and the respiratory rate was 22 breaths per minute. SpO2 was 92% in room air. And on examination, that was equal bilateral air entry and no added sound. On circulation, the pulse rate was 108 beats per minute. The pulse rate was rapid, regular, and bounding in character. The blood pressure was 123/88 millimeters of mercury, and the capillary fill time was below 2 seconds. The patient's extremities were pale and warm. On disability, our patient had a normal Glasgow Coma scale, which was 15/15, with pupils equal and reactive to light. However, we were not able to do a random blood sugar due to the limited resources. And on exposure, our patient had a temperature of 39.2 degrees Celsius, and there were no traumatic injuries. Next slide, please. So our first poll question for today, we from the primary survey findings, what are the most likely emergent conditions in this patient? So please, people from the audience, you can go on and fill in the poll questions. We are going to use 1 minute to do this, then we are going to continue with the presentation. Okay, I think 1 minute is done, so I think we should proceed, if that's fine. So these are our emergent priorities. So our patient had tachypnea and hypoxia. This was evidenced due to the respiratory rate, which was 22 beats per minute, and the SpO2, which was 92% in room air. So we intervened by giving the patient 2 liters of oxygen by nasal prongs. Our patient was also dehydrated. So we intervened with giving normal saline 1.5 liters. And our patient also had a fever of 39.2 degrees Celsius. So we gave TABS PCM, 1 gram stat. We encouraged tepid sponging and removed excess clothing. One might ask why we gave TABS. This was because our patient was not vomiting and she could swallow. And we also could not access IV PCM, so we opted to give TABS PCM. Next slide, please. Okay, so moving on, we did our sample history, and our patient had severe generalized body pain. She had bilateral knee joint swelling. She didn't have any allergies, and she was on unknown medication for a chronic illness. Our patient reported numerous admissions in her lifetime due to similar episodes. However, this year, this was her second admission due to similar signs and symptoms. She also reported 8 previous blood transfusions. Her last meal was 6 hours prior to admission. And events leading to the presentation, our patient was in her normal, usual state of health reporting no clear trigger for this incident. So moving on. So anyone from the audience, please, in the chat, you can ask any additional information you would like to know about this patient, and I will answer. Hopefully, we shall take only 1 minute for this.
So please put up your hand so that we can see you and we help you unmute. Or type your questions on the chat. There is a doctor as well who is going to be answering them. So please unmute. Okay, let's carry on.
Okay, carrying on, I would call on to Dr. Joseph to please share with us his initial thoughts and what he would have done differently in this patient so far. Dr. Joseph, please.
Thank you very much, the presenting team, for so far what you have done for this patient. I do have a question before I can approach. So you mentioned that this patient had received the blood transfusion 8 times for sort of a similar presentation. And in my mind, I was wondering, 8 times, did they try to investigate, and what kind of blood transfusion? Was it red blood cells? Was it platelets? Was it the other clotting factors? Maybe I'll begin with that, then I'll come in.
Okay, our patient, her last encounter in the hospital, yes, she was transfused with packed red blood cells because she had severe malaria.
She had severe malaria.
Yes.
The last time. Okay. Yeah. All right. So, and then the other thing, the location of the patient, I would assume that is the patient is in Uganda. All right. Thanks. So, so far from what you have done, I think you have tried to follow a rapid, systemic, and patient-centered approach, and you've the pre-hospital went and got the patient and identified a few things, and then you did the ABCD assessment, which I think you did it systematically. You went through the airway, the breathing, the circulation. Now, in the circulation, what I did not hear from you was the heart sounds. Given what you have talked about this patient, she has a fever, generalized body pains, and fever, generalized body pain, and joint swelling. So in this kind of case, I would be interested in the heart sounds. And the reason for that, sometimes you can have infective endocarditis. And then the other thing I think I would be interested in this patient in the history would be something connected to the genitalia. Any signs of maybe abnormal discharge, because again, there are some infections like gonococcal infections that can actually get an affected joint. However, what I would do differently, I would dig in more of the history after that basic assessment and initial, but I would have also started this patient straight away on a broad spectrum antibiotic, because already I sense that this is going to be the direction of infectious sepsis is going on, possibly a bacterial infection, and maybe on some underlying, it could be some underlying pathology going on, and then the bacterial infection comes on us. But I'm going very far to the diagnosis. The question is, in my mind, when I'm receiving this patient, I should be able to rapidly do the ABCD assessment, and then I should do a little bit of history for the pain. You have heard of the famous OPQRST acronym. You have to onset, provocation, state, palliation, quality, radiation, the site, and then the timing. Those factors are very, very important in trying to make you understand the possible causes of this pain. But for emergent parts, I wouldn't do much different, except I look at the heart sounds, start this patient on antibiotics. Thank you.
Okay. Thank you so much, Dr. Joseph, for that enlightening information. So when we did our cardiovascular system examination, the heart sounds were normal. S1 and S2 were hard, and there were no additional sounds. So, and we are going to see that in the secondary survey. So when we did our head-to-toe examination, so for the general exam, our patient was alert, she was conscious and oriented, she was not in respiratory distress, she was moderately dehydrated, she was not cyanotic, there was no finger clubbing, and there was no lymphadenopathy. For extremities, she had bilateral lower limb pitting edema, which was grade 1. And on genital urinary, there was oliguria, there was suprapubic tenderness. She reported increased urgency and frequency of urination, and she also had painful micturition. On musculoskeletal examination, she had bilateral knee joint swelling. The joints were warm and tender to touch. There were no deformities or erythema noted. However, on other systems such as the cardiovascular system, the respiratory and the abdomen were, and CNS were normal, so they were unremarkable in this point. Next slide, please. So if you'd like any other additional information about our patient, please feel free to ask and I'll answer.
Again, our audience, feel free to also type in your questions in the chat. They are being answered, and yeah, raise your hand and the host will tap on you, unmute, and we shall be able to answer your questions. Yes. So in the general page, I am seeing a question: where were the micturition habits in case of any, please? So you could answer that.
So for the micturition habits, we have said the patient reported painful urination. She also reported increased urgency and frequency. I don't know if that is helpful.
Right, and the other question was answered, the samples were taken. So if there is no one who is raising their hand, I would then implore us to proceed at this point.
So Dr. Joseph, if you have any additional thoughts at this point, please.
Okay.
Welcome you to.
Yeah, thank you. I think you mentioned painful urine and the quantity. I would also be interested in the color of the urine, and the reasons for the color. Sometimes when you have things like rhabdomyolysis, things like black water fever in malaria, things like that can actually be a useful indicator to a clinician that something is going on. But even things like nephritic syndrome, just the look of the urine without you actually doing an investigation can give you very useful information. That's what I would be interested in. And I think so far that's what I can comment regarding the urine.
Okay, thank you, Dr. Joseph. So our patient reported decolored urine. So in the investigations that we were able to get, and all the investigations that we ordered for complete blood count with differentials, and we can see our white blood cell count is elevated. Our lymphocytes are also elevated. Our HB is severely low, and our platelets are also elevated. Then our LFTs, we can see that direct bilirubin. We can see that overall we have a significant elevated bilirubin. However, we can see that indirect bilirubin is so high. And in our case, that pointed us to an ongoing hemolysis. We can see that the AST is somehow high, mildly high, but that is not worrying. It could be due to mild liver injury, but we can see that ALT is normal. So moving on to RFTs, we can see that there is significantly increased creatinine levels. We can see it's 3.33 milligrams per deciliter. We can also see significantly increased urea. So this and my team pointed us to an ongoing maybe kidney injury. And then we also did a urinalysis, and we can see there was positive nitrates, past cells, and trace blood. We did a blood slide for malaria parasite, however, it came out negative. So at this point, I would like to inquire from the audience what their differentials are. Please answer in the chat, and we see if we are at the same point. No.
Our dear audience, the poll questions are for you to answer, not to admire, but we appreciate those who are answering. We are seeing the answers are really lovely. Please continue doing that, and feel free to unmute and ask or type questions on the chat as well. I may ask as they are filling them up. Was the blood slide? Yes, it was negative. Was there an RDT that was done just to ensure that the laboratory technician was not tired of that day and missed the parasite?
Yes, we did an MRDT, and it also came out negative.
Oh boy. All right, we can proceed at this point.
Okay. So moving on to the next slide, I'm going to share our differentials that we were able to come up with and why we have supportive findings and contradicting findings. So in no particular order, we thought maybe our patient has sickle cell vaso-occlusive crisis. And this was because our patient was a known sickle cell patient, and she presented with generalized body pain for 2 days, which was severe, and she also reported numerous admissions for similar episodes. She had bilateral knee joint swelling, she had severe anemia of 6.3 grams per deciliter, and she had a fever. So to us, this was a textbook vaso-occlusive crisis. However, in our patient, we didn't really see anything contradicting this differential. We also thought maybe she could have had septic arthritis. This was due to the joint swelling and the fact that our patient is a known HIV patient for 2 years. We thought since she's an HIV patient and at the same time a sickle cell patient, she was at an increased risk of having septic arthritis due to the impaired immunity. And also the warm and tender knee joints, the fever, and the leukocytosis. All this was supporting septic arthritis. However, this was bilateral knee joint swelling. But for septic arthritis, usually affects only unilateral joints. And we also did a joint aspiration, and there was no pass. Also, our patient, oh, never mind. Okay, moving on to UTI. Our patient had, okay, a history of increased urgency and frequency of urination. She had dysuria, she had suprapubic tenderness, and on the lab investigation, she had a positive nitrates, and pastels. And malaria, we already ruled it out due to the negative blood slide and MRDT. So moving on to our ED course. So we decided to go with our working diagnosis being UTI, which could have maybe exacerbated the vaso-occlusive crisis. And then the vaso-occlusive crisis led to the kidney injury. And since this was our first encounter with our patient, we decided to choose acute kidney injury because this was our first time meeting the patient in the ED. So we didn't really get to rule out if it was either acute or chronic kidney injury. So at this point, I would like to ask the audience what they think their management priorities for this patient would be, since we already know the diagnosis of our patient.
And with the poll questions ongoing, that is where you will choose your management priorities. And I love the fact that the slide will be shared. I love the fact that the team, the expert will expound on this, but thought about the acute kidney injury and thinking about what would kill the patient first at this point, as opposed to what they have been having all that time. The poll is still running on, as we are left with a few seconds to just close it. Feel free to accomplish it. Not the end of semester exam. Right, let's continue.
Okay, moving on. So our patient, we continued with oxygen therapy because remember, this is a sickle cell patient. So we wanted to make sure our SpO2 was above 95% in room air so that we can reduce on the sickling, the red blood cell sickling. We also gave oral morphine. Well, first, because we didn't have IV morphine, so we opted for oral morphine, which, if you remember the WHO ladder of managing pain, so our patient had severe pain, so we opted for oral morphine, which is more like the first line for this kind of pain. We continued with tabs paracetamol 1 gram because remember our patient had a fever. We also encouraged the caretaker to continue tepid sponging. Then we gave IV fluids, 1.5 liters in 24 hours. I'm going to explain why we gave only 1.5 liters. We also transfused with 460 mils of packed red blood cells because our patient was severely anemic. Then we gave IV ciprofloxacin for empiric treatment of the UTI because we didn't do a blood culture. And we all know if we had done it, it would have taken long to come back. And then we also gave folic acid because remember, due to chronic hemolysis and increased folate demand, the bone marrow is going to work harder to produce new red blood cells. So meaning the folate stores are going to be depleted. So that's why we gave the folic acid. So one might ask why we gave only 1.5 liters in 24 hours. But in sickle cell patients, it's the guidelines usually encourage us to do the maintenance fluids, which you calculate using the Holiday-Segal's formula. Then you multiply it by 1.5. You multiply 1.5 times the maintenance fluids. And this is because we need to do aggressive hydration in our patients. But for our patient, we gave half of that fluid because if we had calculated, it would have been 3 liters because our patient was 46 kgs. We gave half because we didn't want to risk fluid overload. Moving on, please. So at this point, I would want to invite Dr. Joseph to share with us what he thinks the powers and pitfalls in managing sickle cell patients with AKI is. Dr. Joseph?
Thank you very much for this again. So I've looked at your management plan, and I do agree with the plan. The only difference I would make for my assessment, this patient is very sick. To me, is very sick, and well, if I really don't have an option of giving IV drugs, that's when I would really give the orals, because again, you want the drugs to get into the system and start acting immediately. Sometimes when you do these things orally, it can trigger things like vomiting, but also we understand when absorption of drugs in the body, there is that loss of medicine. So you may not achieve the exact effect. So that's why I would get them to a point where I would start them on IV drugs. Then I could switch. Then I could switch later. You mentioned very well. You got to be very careful with the way you're giving fluids. But again, in this patient, this when they are hemolyzing a lot, you break a lot of red blood cells. That part of the hemoglobin can go and come through the kidney, and you need some sort of, you calculate the fluids very well, and you've got to a bit add, as you said, you have to multiply by 1.5 so that you're able to facilitate the clearance of that hemoglobin from the system. And it's one of those things that can cause acute renal failure in this kind of patient. So fluids is very important in patients with sickle cell. It's not just about the AKI, but also restoring vaso-occlusive crisis. When you give a lot of, you open a lot of blood vessels, and the oxygen is able to get in there and other nutrients. So rehydration is very important. If they can drink, you can also encourage them to drink. You can replace some orally, and then also you can replace some through the IV. And then the other thing is pain management. Pain is really very important in management in these patients. And don't overlook non-pharmacological ways of managing pain. I see here we've talked a lot about the drugs, but there are other small things you can do outside the drugs that can improve pain. One of them is, reassuring the patient, and some of them might have to do with the positioning. You mentioned that these patients are the swollen joints. So there are some other remedies called maybe warm compresses, cold. There are quite a number of non-pharmacological ways that you can manage pain. So that also has to come out very well. And then of course we know these patients have a risk of infections, and you must really cover them and infections. And the kind of infections they have, if we remember encapsulated bacteria, you'd have to cover them for those kind of or organisms, and make sure the fluids, the oxygen, since you had the low SpO2, you've done your fluids, your oxygen, you're doing your antibiotics, and then the other thing is that what I would have loved to get from this patient was also electrolytes, though we didn't get, because we really needed to understand the electrolytes, and so that when we are giving some of these fluids, we have to give it carefully. I think about your whole patient. Sickle cell has a lot. You've got to think also of bringing the family on board. And sometimes there are a number of complications that are interconnected. You've got to really dig deep in terms of your history and the examine. Sometimes these things even cause some sort of abscesses in the joint in some other parts of the body. So you would have to take a very good detailed history and things. I'm asking myself, why is the oxygen low? Why is the oxygen low? Maybe there's also pneumonia going on. And then you mentioned of a UTI. I'm also thinking, is this patient having a pyelonephritis? Which could still lead you to AKI. So they are really complicated. You have the patient itself, but also you need to look at the family and other things. So don't, and then the other thing, some of these patients, they have taken some of these drugs, let's say opioids, they have been taking them. So you got to look at their dosing. Their dosing might be a little higher. And you are going to think multimodal approach to pain management. So not only opioids, you can even bring on ketamine at some, but that's in consultation with the expert, depending on the assessment of pain. Again, pain assessment for patients is very important. There are different number of scales, but the easiest one, you can use a numerical scale on a scale of 1 to 10. How big is your pain? And then you got a number of things that you can do, as I say, non-pharmacological and pharmacological. So, and then of course later on when your patients come in, you can evolve in other people. Yes. So far that's what I can say. I have other colleagues. Dr. Linga can add on. And
Thank you so much,
very
Dr.
much,
Joseph.
Thank you very much, Dr. Joseph. Before I invite you to continue, I just wanted to take a pause, and everyone should just suck in the moment that the treatment, we all know as doctors, we know how to try our best to give the medications, give the fluid and etc. But Dr. Joseph hints out a very important point that we need to take home, and that is involving the family members, especially in these chronic diseases, because from time to time they are going to fall sick and etc. So I leave you with a holistic triad of care that has the patient who has the disease, and then the doctor who knows actually how to treat this disease, and then we complete this triad with the family or community or religion. And so when we have all these three components together, even as early as the emergency department, when we initiate them, we are bound to win together as a team. So that is one key power that I want you all to take home as you become better practitioners in this practice of medicine. Thank you very much, Dr. Joseph, for those insights. I would invite Natasha continue.
Thank you so much, Dr. Daniel. So I personally have really learned a lot from Dr. Joseph. So I think we can even stop here. But anyway, next slide, please. So in our series this month, the overall communication we wanted to pass on was maybe the pathophysiology of how AKI is going to come into sickle cell disease patients, and the need for aggressive hydration, pain control, and monitoring, which Dr. Joseph has already talked about. But moving on to how the pathophysiology of AKI comes about in sickle cell patients. So we have two most recognized pathways. So our first being vaso-occlusive crisis. So we have seen that in our patient had vaso-occlusive crisis. And we know during vaso-occlusive crisis, there is basically occlusion of microvasculature all around the body. But for this case, we are concentrating more on the kidneys. So we have occlusion of the microvasculature in the kidneys. And when if there is occlusion, there is going to be shortage of oxygen and nutrients reaching the certain functional units of the kidney. So meaning these functional units are going to undergo ischemia, and then suddenly cell death, and then we are going to have decreased functional units of the kidney. So we are going to end up with acute kidney injury. Then the other one is hemolysis. Maybe if we move on to the diagram, I'll just go to the picture. Next slide, please. Okay, so when we have acute hemolysis, or remember these patients are undergoing hemolysis all over. So we have production of heme and hemoglobin dimers. So hemoglobin dimers are directly toxic to the kidney cells, specifically the podocytes, and this will lead to a decrease in the glomerular function, which will lead to AKI, as we can see. Then also heme is going to bind to alpha-1 microglobulin, and then it's going to go and be deposited in the renal proximal tubular epithelial cells. And when it accumulates there, it's going to cause tubular cell death, and then we are going to end up with an AKI. I think that's easy enough. So moving on to the other overall communication. Next slide, please. Yeah. Okay, so this is what Dr. Joseph has already said, but maybe I'll just repeat it. So we wanted to emphasize pain control in this patient. Like, it's one of the pillars in management of a sickle cell patient. So you have to do pain control because pain is going to stimulate the sympathetic nervous system, and then it's going to lead to a release of catecholamines into the body. And we all know that catecholamines cause vasoconstriction. And when we have vasoconstriction, this is going to worsen sickling, causing more pain. So that's why sickle cell patients hide a lot of pain. So that's why we have to really pay attention into pain management. So how do we do the pain control? So opioids are the first line. So you can give morphine or hydromorphine. So we can also give adjuvants such as NSAIDs, acetaminophen, or gabapentin, which is for neuropathic pain. For our patient, we didn't really go for NSAIDs because remember, we were thinking that our patient has a kidney injury, so we didn't want to exacerbate that. Then moving on to hydration, we wanted to do aggressive hydration, as Dr. Joseph already mentioned, because hydration is going to improve blood flow of the body tissues, and it's going to prevent further sickling. And also, in this particular case, hydration is going to improve renal blood flow and tubular function, thus preventing progression of AKI. So how do we give fluids in sickle cell patients? So ideally, we are supposed to do maintenance fluids. We know how to calculate that using the Holiday-Segar formula. Then we multiply that by 1.5. And then we want our goal urine output to be above 0.5 mils per kg per hour. Next slide, please. So we want to keep a close eye on these patients, the sickle cell patients, so that we can detect life-threatening complications as early as possible. Because if we end up with these complications, the patient might be long gone, like to be saved. By not scaring anyone, they're also manageable. So we can do monitoring vitals hourly, for example, pulse oximetry. We want to also do examinations, for example, the respiratory exam, to check on our patients if maybe they might develop acute chest syndrome. They might also develop pulmonary edema, for example, in our patient, in case we had fluid overload. We want to check on labs such as CBC. We want to do creatinine, LDH, because hemolysis is ongoing. And we also want to do frequent clinical examination. So at this point, please allow me to call on to Dr. Joseph, Dr. Amon, or anyone who wants to add anything onto the presentation. Please, you can come forward. Or any questions about our case, I'll be pleased to answer.
I think at this point, Dr. Mon and others can first come on maybe what I would ask you is, how did our patient do after a few days? If you follow them up.
So unfortunately, our patient, when we reviewed the patient on the subsequent days, we checked our patient and she had a chronic kidney disease, which we could not have managed at our resource limited setting. So we referred her to Mulago to see a nephrologist because she had a GFR of 15.8, which was very low. So she really needed to see a nephrologist and so she could be managed, or maybe put her on dialysis.
Thank you very much, presenter. The presentation, I think, is quite clear. And I think this is one of the things that sometimes is missed, the AKI. It is very easy to focus on the pain that the patient is having and not to look at the kidneys, how they are deteriorating. I think in an emergency setting, it is good to try as much as possible to also try and focus on all the organs. Yes, the patient may be talking about the pain. The patient may not report the AKI. So it is up to us who are managing to try and look for the organs that are failing. So I think the message is that we should also try as much as possible to look at all the organs besides what the patient is complaining. The patient is complaining about headache. Maybe we should also look at the lungs. We should also look at maybe the heart. Look at the organs that the patient is also not complaining about. Yeah, that's what I just wanted to emphasize. Thank you.
Thank you so much, Dr. Amon. Any other question or addition, please? Feel free to bring it forward.
I think we have a question in the chat. It's coming from Kembabazi Grace. She's asking, you say the first line management of pain is morphine. Is that the general approach according to the case?
Okay, thank you so much, Grace, for that question. So remember, our patient presented with severe generalized pain. I'm pointing onto the severe. And remember, we also said we have to really manage this pain because sickle cell patients are really in a lot of pain. So when you remember the WHO ladder of pain management, the third step is opioids because they are strong. And since our patient is in a lot of pain, opioids would have been the first line management in this case. So Grace, is that clear? Okay, thank you, Grace. Any other questions?
Thank you, Natasha, for your wonderful presentation. Thank you, our experts and the team that took part in the presentation of this case and preparation of this case. From the take-home messages, as we can see, is that there are a lot of things that we could have probably missed during this case. And the emphasis here, we can go back from our primary survey, our secondary survey, and a bit of our sample history here is that always be critical and be observant of the different aspects. As in this case, I think some of the questions that we had allowed the audience to ask, I think majority of us missed out the fact that did you ask about the medical history? Because in our presentation here, she did not intentionally bring it out just to ensure that the case is not given out. But if we had asked about the past medical history here, then probably should have told us that the patient was a patient of non-sickle cell disease, and this would have driven our thinking and our mindset towards that area. So the take home here would be, on top of what the experts have said that we that I 100% agree on, would be follow your primary survey, follow everything in the right order, ask the right questions, and keep on being very attentive to your patient. We have a post-session poll. The post-session poll is just going to be take home. What we have learned is just for the assessment to see if there's any learning that has been done. The first question is from the primary survey findings. What are the most likely emergent conditions? This still goes back to what we had seen earlier. Then the second question is, at this point in the evaluation, what are the most appropriate differentials for this patient? And our third question is, what are your management priorities for this patient at this point? This is just to ensure that learning has taken place. So feel free, let us answer the poll questions in this case. And also shared currently on the screen, we have the heroes who have taken part in the case-based learning series. For communication, the case-based learning series basically happens monthly, every last Friday of every month from 7 to 8 p.m. The session materials are usually uploaded. We usually try to share the links for this. We have a YouTube channel that is the SEED Training Hub on YouTube, where you can find the videos of every session. And we also have on the SEED Training Hub website, so you just go and type in www.seedtraininghub.com, the website where we shall have every case, the upcoming cases for every session, and the resources. This presentation is also going to be uploaded there, and also a link to the YouTube channel that you can go back and use as reference for the session. So just showcasing there is that we want to still appreciate you for taking time to attend our presentation series. This happens usually very late in the evening, so we do not take your time for granted. Appreciate the presenters who have taken part, the experts who have led the discussion, the moderators that have helped our presenters prepare for the cases, and the mentors as well. And also we can actually have the diagnoses that we have been having. The secretariat is as well down there. These are the men and women behind the preparation of these cases. So we still have remaining months coming up. If you have an interesting case, you can still reach out to any of the members in the secretariat and you want to do the presentation. But as well, we still have a selection criteria that we are using, and we hope that everybody who has applied to be a presenter in this case will have an opportunity to present. We still have a lot coming up in the course of the year and for the future of CPC as well. So everybody who is invited to take part in the different challenges that we are going to have, the different upcoming case presentations, and the different trainings that we shall have later on. Thank you so much for attending the CPC case-based series of July. The theme was the hematological emergencies. Our catchphrase was, "My body is paining." Thank you so much for attending. Hope to see you next month, the last Friday of the month, for the next case-based learning series. Further information, you can still contact the team. And if you want to be a presenter, if you want the recordings and slides, thank you very much.